Welcome everyone to another episode of You've Got the Power. I'm your host, Dr. Jason Deitch, and of course we are here with Chief Medical Officer of the Centeno-Schultz Clinic in Broomfield, Colorado, Dr. Chris Centeno. Good afternoon to you, Doc.
Good afternoon, Jason.
Welcome everyone. As you know, each and every week here on Mondays at the Centeno-Schultz Clinic Facebook page, Fridays at the Regenexx Facebook page, we are answering your questions about regenerative medicine. Today's topic we're going to be talking about is: what does TNCC, what does that stand for? What does it mean as it relates to the PICL procedure? Doc, let's break down the letters, what it means, and we will be taking your questions as they come on in. Doc, tell us about TNCC and its relationship with PICL. Sounds like a lot of alphabet soup.
Yeah, exactly, Jason. So TNCC simply means total nucleated cell count. So it's the total number of cells in a bone marrow concentrate sample. So it's the total number of cells per cc that's injected. Now, only a tiny fraction of those are mesenchymal stem cells. There's a larger fraction that are hematopoietic stem cells. There's a larger fraction that are macrophages, etc. And as it relates to the PICL procedure, we don't fully know yet, but this wouldn't be one of the applications for bone marrow concentrate that I'd be concerned about the TNCC all that much, meaning that when we looked at this number for knee osteoarthritis, we have to have 400 million or more. And it's very, very rare that we see anything under 400 million in our population of patients that are getting the PICL procedure. So it's one of those numbers that's kind of a red herring, I believe, when it comes to that procedure. But I do see a lot of patients requesting that number. They want to know that number. It's important to them, but I think it's important for patients to understand that it's probably not that important in this context.
What are you seeing as it relates to these conversations? I think that people may be missing. I know everybody wants to, we talk each and every week. Everybody's looking for certainty, and oftentimes certainty is found in numbers. If you've got a number and it fits within a range, you're good to go, and it's certainly either good or certainly bad. But in the world, as we bring to our audience of uncertainty and reality, what are you seeing that concerns you about their thinking, and how should they be adjusting it more specifically?
Yeah, listen, I think there are things you can do to improve your stem cells. You can go on a low glycemic or low sugar diet. You can take the stem cell support formula. You can really try to improve your life as best you can. And that will have an impact on your overall stem cell function. Now, with regard to this particular metric and the number of cells delivered back, or TNCC, or total nucleated cell count, it's probably less important. But what I generally see is, I think what's happening on social media, people are changing these numbers out, saying, well, I got 600 million and I got 1.2 billion, thinking that 1.2 billion must be twice as good as 600 million. And that's likely not the case. So it's an important one just to realize that, maybe you track it from procedure to procedure to try to get some rough estimate of maybe if you're doing a good job on your end. But even then, there's a lot about those cells that we don't know, and that would take a full research study in the lab to figure out for each patient. So it's just one of those things where I'm seeing people being very anxious about this number. They want to get this number. But that number probably, and as my father used to say, a nickel will get you a cup of coffee, meaning that it's not really as critical as people believe it is.
Well, let's go into addressing, it's tea, by the way. But anyway, let's go into addressing the concern behind the question, which is, what are those things? And maybe to break down just a little bit further, and we got a lot of good questions coming in, so we'll go to those in just a few moments. But what you were saying is, people think that number will indicate their likelihood of success. And again, what I'm hearing you say, again, just clarify for everybody, is that there's many more factors that are going to go into the success of their procedure Many of them have to do with nutrition, have to do with your, overall health and well-being, perhaps even mindset, exercise, and those things. Are those things more important for people to pay attention to than just 1.5 million, billion, trillion, whatever the number is, to sort of binarily say good or bad, or I'm going to be fine or I'm not going to be fine? What are those things that are most important for people to pay attention if what they're really looking for is, how do I get the highest degree of certainty that this procedure is going to work to its best advantage with me?
Yeah, and so there's so many different things that would go into whether a procedure like this might work or might not work. Number one, the type of patient, and we're looking at that right now. Number two, the exact place where all this stuff is put. Number three, the patient's anatomy and how easy or hard is it in that patient to get that stuff there. Number four, how the patient's accepting anesthesia and whether or not the doctor has a lot of time to place the stuff where that doctor wants to place that stuff, or whether that's a struggle because of problems with anesthesia. Number five, the overall health of those stem cells in the sample. Number six, the mix of cells, other cells in the sample. Number seven, the number of cells and given ratio of those cells. So again, we're talking about a lot of variables here, and to focus just on one, TNCC, that we don't know makes a difference at this point in 95% of our patients, it is, again, just not tenable or all that important.
Another perhaps version of the shiny object syndrome, so to speak. If you see something on an image or you see a number, all of a sudden that becomes the thing to focus on. We got a lot of questions coming in, so if you're ready, let's head on over to answer some questions.
Sure.
This was submitted in advance by Daniel Semrad. He says, great topic. I will not be able to join live because of work commitments, but if time allows, can you please answer the following questions? Number one, can you please discuss the rough, typical, respective TNCC dosing per CCJ ligament, i.e. typical amount of TNCs injected to treat the alar ligament, transverse ligament, tectorial membrane, and then the PAOM, COC1 joint, and joint capsules, etc.?
Yeah, so as far as, and I think the first question was sort of the average number of TNCC. As we've talked about, the number itself isn't all that important, but if we look at PICL patients in general, they're going to be in the 600 to 1.2 billion range, is usually what we'll see in those patients. And again, that's the total nucleated cell count, and not a stem cell count. So it's the total number of cells in the sample, only a small percentage of which represent stem cells. And then if we go to the amount that goes into each of those, probably better to state that our average injectate volume is around 5 to 6 cc's. And of that, for example, in any one ligament, not more than a half to 1 cc goes into that specific ligament, many times simply because of volume concerns in that space where we're injecting. And many times it just won't take more than that. So that gives you some rough idea of how many of those cells go in there. But again, the absolute number is not all that important at this time.
All right, we're taking your questions. If you've got them, we take them in order that they come on in. So now's a great time to ask. We've got more coming in, Doc, here. So this is also from Dan. He says, number two, what other types of cells are in the BMA, and what happens with those other non-stem cell cells when they are injected into a ligament?
Yeah, so there's a lot of cells that we're talking about here. So for example, we've got mesenchymal stem cells, which is probably the smallest population. We also have, outside of mesenchymal stem cells, hematopoietic stem cells. We've got macrophages, white blood cells, red blood cells, platelets, and a whole host of other cells. Just within the white blood cell family, there's 5 or 6 as well. So lots and lots of different cells make up bone marrow concentrate. Now we believe that bone marrow concentrate's actions are due to, number one, the mesenchymal stem cell content, but we also think probably the macrophage content, and even it gets so complex because even within the macrophage content, then you've got to look at things like activated versus non-activated macrophages, M1 versus M2. So just realize that this stuff gets pretty complex pretty quickly, and it's not something that you can generally point to and say, aha, if I've got exactly this much, I will be fine. So just recognize that that's the kind of stuff we're talking about here. High levels of complexity. And we're not even talking about things like cytokine content. So for instance, IRAP would be one of those cytokines in the bone marrow concentrate. Another cytokine outside of IRAP would be things like, or growth factors, things like vascular endothelial growth factor, transforming growth factor beta 1, FGF, et cetera, et cetera. So high complexity involved in what we're discussing.
Not very consumer friendly to understand these things, but that is, I guess, a signal to everybody that that doesn't mean you just abdicate it. You know, it's too complex. I shouldn't learn about this stuff. You know, just trust whoever is most convenient, local, and cheapest. But really knowing enough to know what makes sense, what doesn't make sense, and keeping into context exactly that context that, you know, certain things matter within the larger circumstance or situation, as in your whole body, mind, and spirit that goes into who you are and how you heal. Let's keep going. We got, let's just acknowledge Shanzen. She's doing a great job writing down people's names who should be watching the show. So thank you for doing that. If you would like to invite other people to watch the program, you can type their name in the comments section. If you're friends with them, their name will appear and they will get a notification to say, hey, come on, watch the show with us. So Shenzan, thank you for doing that. Next question from Adrienne Cuvion Barnhill, regular viewer. Hello, Adrienne. She asks, I see regularly that patients returning sooner than 6 months have declining TNC with each procedure. I know this does not agree with your studies, but it seems it's seen a lot with PICL patients. Where does the risk-benefit ratio lie with repeating PICLs within the 6-month mark, knowing that their TNC may be lower with each treatment if done in that time frame? While TNC may not reflect total stem cell count, a pattern of declining with each procedure is hard to swallow.
Yeah, it generally doesn't. So we just looked at all of this. Meaning that the lab staff looks at these things, and we actually have an upcoming paper on this. Hasn't yet been submitted, probably won't be submitted. My guess is for another probably month or two, because we're currently writing the paper, all the data analysis is done. But there really isn't a big relationship between those two things, meaning repeating a procedure within 8 months and the total nucleate cell or the stem cell content dropping. Now, the one caveat to that, and I've talked about that here on the show before, would be in women over 55 or 50, meaning postmenopausal women, where we see a small effect. And so if you're after menopause and female, then we can see this. And that means that when you return for your second procedure, a different type of procedure will be performed if you're within that 8 months. If you're outside of that 8 months, then there is no effect even in that group. So the bottom line is, if you're coming in at 4 to 6 months and you are male or female and haven't yet gone through menopause, then there should be no issue. If you're female and you have gone through menopause, then that's something that can be helped simply by changing the type of draw that's being done, meaning we use two main types of draws that source cells from different spots. So, I've been doing that in my patient population for the last year or so, and that should be done in all PICL patients as well.
All right. Moving forward to Dan Semrad's third question. He says, is there a difference in the healing response between pure cultured stem cell injections and BMA injections? And can the other BMA cells cause an immune response resulting in scarring on a microscopic level? Can repeated BMA injections then lead into thickening of the treated ligament as disorganized collagen is laid down versus tightening?
Yeah, never seen that, meaning as we have treated, for instance, other ligaments that we can see very, very easily on MRI, like ACL, we generally don't see anything but reorganization into a tighter collagen configuration. So that's generally not something we have seen in larger ligaments we can observe. And those are pretty much exclusively treated with bone marrow concentrate. The other option would be to inject isolated and cultured mesenchymal stem cells. And the problem with that idea is the only place we can do that is down in Grand Cayman, and Grand Cayman does not have the facilities to do PICL. Biggest problem there being that Grand Cayman just doesn't have the ICU capabilities in case something bad were to happen. Now that's a very low likelihood event, but I've always said the best ICU in Grand Cayman is Miami. So because of that, it's not something I'd feel comfortable performing down there at all. So bone marrow concentrate works, and that's where we're focused right now.
Right on. All right, we've got our regular viewer Stacy Kaufman. Hey, Stacy. She says, I'm so confused. Why take the stem cell formula and why spin our blood products to concentrate if the count may not be important?
Well, so now we're talking about two different things. So now we're talking about a bone marrow aspirate, which is what we would draw, versus a bone marrow concentrate. So a bone marrow aspirate would have X number of total cells per cc, and a bone marrow concentrate for us would have about 10 to 20x that number. Now, we're not talking about bone marrow aspirate, where we would have probably significant issues if we just use the bone marrow aspirate, but we're talking about the bone marrow concentrate. So is this bone marrow concentrate that contains more cells than bone marrow aspirate by 10 to 20x very different in its ability to heal than that bone marrow concentrate? And the answer is likely not. But if we were talking about bone marrow aspirate before we concentrated, that would be a completely different conversation.
Right on. Hope that helps, Stacy. Thank you for asking, and thank you for watching. All right, submitted again by Dan. Question number 4, here we go. Are there developments on the horizon that would allow you to better filter stem cells out of the BMA for the same day procedures? Is that something that is or isn't important in your view?
I don't think anyone would know right now what to filter out. So that would need to be sort of a lab theory that then got tested in animals and then got tested in humans. So we're talking about hundreds of millions of dollars, because that would also require FDA approval as a drug. So if we were to substantially change the composition of what's in the bone marrow, and in that case, that's what would happen, right? We'd be taking out certain cells we wanted or taking out cells we didn't want, either way. Now, all of that's possible to do through what's called a mag-sep column, or magnetic separation column. But again, it would basically mean that we were creating a drug that would cost several hundred millions of dollars and about 10 years to get through the FDA gauntlet to use. So regrettably, while that may make some sense to do that research, it would be cost prohibitive to do that at this juncture, and would take a very, very long time.
All righty, Dan, thank you for your questions very much. Shenzhen Khan says, hi, Dr. Centeno. Do stem cells work better for disc bulges and herniations, or do you recommend starting with PRP if that's more conservative?
Well, depends on what we're talking about. So if what we're talking about is a painful disc with a tear, then high-dose PRP, leukocyte-rich, works very well. We have a randomized controlled trial on that that shows that it works very well. So, and that's also been my clinical experience as well. Now, if we're talking about a disc herniation, really what we're doing with the disc herniation, that's where the stuff inside the disc squirts out, is we're trying to get the patient through that while not messing them up too much until to ramp up the body's ability to take that disc herniation stuff away. In which case, a platelet lysate epidural injection, in my clinical experience, works well. Then we get into a disc bulge, and the easiest way to treat a disc bulge is to treat the nerve that's irritated, and usually the problem goes away. But if we absolutely need to get rid of the disc bulge, then the only technology I've seen that can do that on a reliable basis would be some of the specially cultured cells we use in Cayman. But that type of procedure has such a narrow range of patients for who it works that most of our patients really wouldn't be a candidate for it.
All righty. Thank you, Shenzhen. Let's keep going. Adrian's got a follow-up, or another one anyway. She says, what is the absolute best fasting practice for improving stem cell health? Can fasting affect the actual count? Studies are clear that a 24-hour fast or a 4 to 5 day fast mimicking diet improves regenerative capacity in the short term, but is there a benefit to fasting regularly?
Yeah, now I think we're on to a topic that we have good in vitro and in vivo data on, but we don't have much clinical data on. So what I mean by that is that we know based on what we can do in a lab that fasting may help your stem cells. And it makes sense that that would work, but we don't really know whether or not that really improves the efficacy of the type of procedures we're talking about. But if we stay just with the lab concept, then yes, intermittent fasting, I think, can improve the health of your stem cells based on that data, and may also just help improve overall general health. So I think that's a good thing to look at, assuming you're able to do it, right? Assuming you're in that situation where you can easily do that. That's a good way to put your body into a scenario where you're forcing it into a mode where it wants to be healthier without having to, go pound weights at the gym, obviously, and because that can be very, very difficult to do for our patient population.
Absolutely. Thank you for that question, Adrian. Excellent. Let's get back to Dan has more. Dan's fifth one is, what X-ray contrast medium do you use? Is it iodine-based? Thank you.
Yeah, not iodine-based. So meaning not iodine-based in the same way that you're thinking. So there used to be a long time ago, and I think there still is, a type of iodine-based contrast dye that's used for kidney studies, or what's called IVPs. And many patients had a reaction to that iodine-based dye. Now, since then, we have more sugar-based contrast dyes that are complexed, and people don't react in the same way to those if they've got an iodine allergy, which has been shown now for quite some time in the interventional pain literature. So we use contrast, usually IsoView is what's used, and that's not something that has any known allergies or crossover with people who have iodine-related allergies.
Excellent. Dan, thank you for your question. Next question from Arpita Chada. I hope I said that right. It says, hi, Dr. Centeno. What is your take on wearing a cervical collar after prolotherapy, and for how long should one wear it?
I don't generally do that simply because it's a two-edged sword. You might help ligaments heal, but you're also going to cause muscles to atrophy. So you might help one thing, but make another thing much, much worse. So in that situation where one thing is helped and the other is made much, much worse, I try to focus on just not doing that because you really don't know which of those two are going to be driving what's going on. Is the ligament healing, the extra ligament healing you might get from it, going to drive past the additional muscle atrophy, or is the muscle atrophy going to be worse than any benefit you get from healing the ligament? We don't know the answer to that question, but I can tell you there's substantial muscle atrophy because if I put your leg in a cast, for instance, for even 6 weeks, and I take the cast off, as you've probably seen, maybe from when you were a kid or had a broken bone or you had a friend that had a broken bone, once that cast comes off, that muscle is dramatically smaller. So there's a huge effect of immobilization on the strength of our muscles.
So critical, and for everybody, that's such an important point, is to not just stay focused, but to have peripheral vision, so to speak. What's the impact besides the direct laser focus of what you're intending? Adrian follows up, to clarify, is there a benefit to fasting regularly in preparation for the PICL versus only fasting immediately prior?
Well, Justin, listen, I think there are health benefits to intermittent fasting. I think we know that now, and I think there's enough research on it to say that that's a real thing. So, so obviously you'd want to try as much intermittent fasting as you can get done. Now, for some of us, maybe because you've got blood sugar control issues, intermittent fasting is much tougher than not. And so, number one, you may want to try a fasting mimicking diet, which is decreasing your calories, usually to 600 to 1,000 for the day, somewhere in there. You also may want to just do that before the procedure if you have a particularly tough time with either a fasting mimicking diet or fasting, meaning fasting for some people is much easier, I've noticed, than for other people. Meaning if you tend to have a lot of blood sugar issues, fasting can be really tough for those patients. So just be a little careful there. You have to find what works for you, not just a hard and fast thing. And as you probably noticed, if you've been on a diet before, some diets are easier to tolerate than other diets. And just outright fasting is a pretty tough one for many patients to tolerate.
Yes, it is. And then there's intermittent fasting, all kinds of others. And I think the takeaway is that the healthier you are, the likely better you'll do. Is that a fair enough takeaway?
And then intermittent fasting is, we didn't really talk about, or picking a time during which you don't eat. Those are good things. So again, you can say, I'm not going to eat before noon, or I am going to not eat after noon and have a large amount of time in there where you're not eating, or I'm not going to eat after 5 p.m. and I've got from 5 p.m. until the time I wake up the next morning where I'm going to eat. Even that kind of intervention where you're just picking a place where you're not, a time during which you're not going to eat that's at least 8 or 12 hours long, has been shown to have effects.
Excellent, excellent. Let's go back to Stacy Kaufman. Can autoimmune disorders affect how well the body accepts or rejects injected cells in a PICL and or posterior C-spine injections?
Well, they're your cells. So I imagine, again, if the body were rejecting its cells before, it will reject the cells after, meaning there is no way, we're not adding in any other cells that didn't come from your body. So that's surely not something that I think would be a concern. Now, if we're using someone else's cells, then that obviously could be a big concern. But these are your cells, so they're going to have the same amount of rejection or reaction as they did when they were sitting in your body.
Excellent, excellent. All right, another one from Sean Chad. Sean says, hi, Dr. Centeno. Does recovering fast from posterior injections indicate also fast with PICL? I'm not sure that meant. Does recovering fast from posterior injections indicate also fast with PICL? Okay, does that make sense?
Yeah,
Yep. And
it
if
does. Yeah.
so, would you consider performing a more comprehensive PICL procedure because of that? Thank you. Sorry for that confusion.
Yeah, yes, in general, I think those two things are related, meaning recovering quickly from a posterior injection and recovering quickly from a PICL injection. Having said that, this is where I think we get into trouble with PICL patients in that many are traveling from a distance. They've had this for a long time, so they're obviously and understandably anxious and want to get all this over with. So they want as much as possible as soon as possible. The problem is that for some PICL patients, that's a disaster waiting to happen. So what I mean is that we have about a third of our patients where less is more and not the other way around. More is less and less is more. Meaning if you do less, they'll do better and you work into doing more than if you start out injecting everything but the kitchen sink. So the answer is yes, there's generally an association there. But that's something I would need to look at as your doctor on exam, on your other history with procedures, to see how much we can get away with out of the gate, and also to try to respect that, because if we don't respect that and you're in that 1/3, then we're just going to flare you up much more than is necessary, and you're not going to do as well as when we do less out of the gate.
That's such a hard concept for so many people to appreciate and understand, because we tend to live in a more is more world.
More is better, more better. But
one of the
not
ways,
always in this case.
one of the ways I learned that early on, just to share, was that if you had 10 people in front of you who all had instructions for you in order to do something better, if you had one person share their instructions, you probably could hear them and respond to them. If 2, 3, or 4 people started giving you instructions at the same time, you wouldn't get the same type of ability to respond because you'd now be confused. So for those that kind of go, but more is more, by definition, that's one of the ways to sort of think about sometimes being more focused and pacing things out, getting 10 individual messages as opposed to 10 at a time might be an easier way to sort of understand why that is a phenomenon the way it is. But let's keep going. We've got Shenzhen Khan says, this question is not related to stem cells, but more on the diagnostic front. Can I please ask if the mid-neck, example C5, is fully locked, where it doesn't move with flexion or extension, then in your experience, have you seen the mid-neck lock to support the CCJ after trauma, or because it's been injured itself? My neck is now showing more of a reverse S-curve from the side view, as well as some scoliosis.
Yeah, generally those areas are injured as well, or have been degenerative for some time. I think the thing that is hard for patients to understand is that if we take someone who's, let's say, 45 years old, and we look at their neck and we see some lower cervical degenerative disc disease, or let's say 45 to 50, and we go out on the street right now and we find 100 people who have never really had a day of neck pain that they would really point to as a big problem, and we, in the same age range, and we x-ray those necks, we're going to see the same thing in about half of them. So lower cervical degenerative disc disease is a function of getting older, and sometimes it's clinically significant, and sometimes, many times, it's not, meaning it has no implication as to whether or not someone hurts or doesn't hurt. So when we see that, just be careful as even ascribing it to the accident or the injury, because without an x-ray before the accident, and in someone who's middle-aged, it's hard to tell whether that was there before and just asymptomatic or not a problem. Like I said, we take those 100 people off the street, half of them are going to have that, but they've never had any neck pain, and they wouldn't tell you that their neck is an issue that they even notice on a day-to-day basis.
It's the hardest part about what we do is people understanding and sort of looking beyond the pain. Too many people confuse pain as the problem, as opposed to pain being the body's way of saying, pay attention inside now because there's a problem somewhere. And it's just very difficult. Again, another metaphor for what it's worth. If you step on a dog's tail, it barks out of its mouth. But that's not where the problem is. So there's often a disconnect between where it hurts and where the actual cause of the issue is. It can be complex, but that's the reality of the human body. Roger Chin, regular viewer. He's asking, did you take a look into the seasonal variations in TNC count yet? I'd asked about that a few months ago. Thanks. I know you had, I think, written a blog on it. I know you talked it up a bit. So what's the update?
Yeah, Roger, if you just go to the Regenexx.com site, and I don't think it's too long ago. Let's see how many blogs back that was. That's actually still on the first page of the blog. So if you go to Regenexx.com, 2X's, go to the blog. It's going to be 1, 2, 3, 4, 5. It'll be the 6th story back on September 14th, 2021. And the answer was it didn't impact anything. So it was a great question. And like I told you, when you asked it, I was intrigued by if there could be a real difference, but we didn't find one. But I did have a research scientist look into it because it was an easy question to answer, meaning it took maybe 4 or 5 hours of someone's time rather than 50 or 100 or 200 or 300 hours of someone's time. And there wasn't a difference, but it's the September 14th, 2021 story on the Regenexx blog.
Thank you for asking that, Roger, and great thinking. I mean, that's the beauty of really this program is you all can sort of share your thoughts, what you're thinking. No one knows everything, and this is a conversation very much for us to continue to learn together. Clearly, some of us, as in Dr. Centeno, know more than all of us, but that doesn't mean we know everything. And that's the point for research and science, and asking all these questions is to keep on moving the science of all of this forward with questions exactly like that. So thank you, Roger. Doug Smith, if the count of cells is really not that important, what is the advantage of the Regenexx SD procedure? Bone marrow concentrate, which produces many times the number of those cells when compared to the basic machines some doctors commonly use.
Yeah, but so again, I think what we're not understanding there is we have so let's now, we have 3 things we're talking about. Before we were talking about 2, bone marrow aspirate and bone marrow concentrate. So if we've got bone marrow aspirate, it's got this many cells down here. If we've got bone marrow concentrate through Regenexx SD, it's got that many cells up there. And the bedside centrifuges produce number of cells in here. So we're comparing Regenexx bone marrow concentrate to Regenexx bone marrow concentrate, in which case for this particular procedure, we're not seeing big differences there outside of a single application that we can identify right now, and that would be knee osteoarthritis. And for tendon ligament healing, we've never really seen that type of relationship. Now, we continually look for it. And if we see it, we'll let you know, because in fact, that was just a topic of one of our research meetings 2 weeks ago. Now we're talking about the number of cells in a bedside machine where, again, I think you're going to see a difference, right? Because now you've got a much lower concentration, about a third is concentrated, and you're going to have variation in that from high and low based on the number of cells that was in the patient. So just like in bone marrow aspirate, where this would be a bigger problem, in a low dose bone marrow concentrate, this is going to be a bigger problem. But I think we're not seeing these things because we already get the cell number so high that we're above that threshold. And these are threshold items, meaning when we look at this issue, whether it be total nucleated cell count or CFUF, which is a stem cell number, for instance, in knee osteoarthritis, and we're about to publish on this one, or at least submit it here in the next month or so. That'll take anywhere from 3 to 6 months to get published. Those are threshold issues. What I mean by threshold issues is once you get past a certain amount, you're good. It doesn't matter how much above you go there, nothing else happens. you see, quote, the effect. But if you're below that amount, then you tend not to see the effect, or it's less likely. So again, it's popping above that threshold. That's why we do what we do, is to make sure that we get as many patient samples above that threshold as possible. But if you're living, the threshold is here and we're concentrating up here and this is our range, and you're only concentrating to here and you're getting some patients above that threshold, other patients not above that threshold, then that's a problem.
That sounds a lot to me like back in school days when you had some classes that had grades where the harder you work, the better you did, and other classes that were just pass-fail. You either passed or you failed.
There you go.
And just an easy way, a pass is a pass regardless of how well you do. Is that kind of the same mechanism? It's binary that way?
Yeah.
Yeah.
Yes. I mean, it's just a threshold, right? So for instance, what's another threshold issue in medicine? Awful to say, but death is a threshold issue, right? You can be really, really sick, but there's certain things that can go above that threshold where you're just not going to survive. So that's one threshold issue in medicine. But this cellular medicine component is very much based on that threshold. And the goal is to concentrate well above that threshold, so the individual variation in samples doesn't really make as big a difference. Now, that doesn't mean you still might not see a sample that's below that threshold, in which case, you want to try to identify that and try to deal with that as best you can. But the goal is to push enough people above that threshold where you're not running into those issues.
Right on. All right. Adrian's going to follow up with, you were on my mind with this question, although you're far from the only one that isn't a postmenopausal woman I was thinking of. Were there any differences besides season? For example, your general health?
Well, we looked at seasonality in that blog. And so that's the only question we looked at. Now, generally, if you're older, then you tend to have, there's a trend towards fewer total nucleated cells per cc. But that trend tends to be at the margins, so really old and really young. So if you add in really old and really young, you tend to see an effect there. Males and females, females tend to have fewer cells than males. As far as health status, the problem there would be defining what that's like, meaning, so for instance, we know that if you've got a metabolic syndrome, you don't have fewer cells, but we know that your cells aren't going to work as well as someone who doesn't have a metabolic syndrome. What I mean by metabolic syndrome is that you're overweight, you've got high blood pressure, you've got high triglycerides, and you've got an unstable blood sugar. So you are pre-diabetic. We know that people in that zone don't have fewer cells, but their cells don't work as well as compared to people who don't have that. So that's why we talk about diet. We talk about trying to get your diet under control, trying to eliminate as much sugar as you can. That's what this morning's blog was on, and how that sugar impacts things. And so we work with patients to try to do that. We give them that information. Obviously, many patients will respond to that. Some patients won't, right? Some patients will just say, well, let it ride. I'm going to see if this works. I don't feel like changing my diet. And that's okay too. But it's all about just making sure patients have as much information as possible.
Right on. No, I guess that's sort of a news flash. Your health matters. We'll keep it simple, but that's the takeaway. All right, we've got our friend Rachel Riggs. Here we go. She says, I'm scheduled for a PICL in 2 weeks. I just got some info from UMass Medical School researcher who's looking at my blood as part of a study. I have sky-high IL-9 cytokines and very low 1.75 IFN gamma, which indicates complete exhaustion. Will this affect the outcome of the PICL? Thank you.
I don't know. It could. It's certainly possible that it could. I mean, we are decades away from that type of understanding of this procedure. So the answer is it's possible. IL-9 is, has to do with hematopoietic stem cells. So we're not really relying on hematopoietic stem cells here. So as far as that's concerned, hard to say whether it would have any impact. But again, not something I can even comment on as to whether or not it would have an impact on this specific procedure.
All righty. Thank you, Rachel. We have Arpita Chada. Hi, Dr. Centeno. Is it concerning if, scenario, you were 2 weeks post second prolotherapy and were progressing well, but have a setback post an aggressive electric acupuncture with massage? My head is going upwards uncontrollably. Would you suggest Botox to SCM to control this? My third prolotherapy is in 2 days.
I would need to know a lot more about what's being injected in the prolotherapy, how it was being injected, where it was being injected, who was doing the injection. In general, we don't recommend Botox for patients with instability because that reduces muscle tightness, and many instability patients need muscle tightness in order to function normally. Because they don't have the ligament stability, their muscles try to take over. So if you reduce that muscle tightness, you'll generally make most unstable patients worse. So that's something we consistently hear from CCI patients. Those CCI patients seem to be doing okay. They were kind of getting along, but having issues. They go into a neurologist. Neurologists love to do Botox because it compensates very well. And they'll inject Botox, then the patient will be blown up. And the hard part about that blow up is it's going to last for 3 months because that's how long this stuff works to relax muscles. So in general, not a good combo there, but I'd have to know a lot more to answer that question in your case specifically.
Excellent. Thank you for your question. And that may be to reach out if you want more details on your care for an online consult if you're not local, if you want to learn more about potentially how Regenexx or how Dr. Centeno can help you specifically. Lindsay Johnson asks, can cervical instability cause severe jaw spasms that cause issues with talking?
Yeah, I mean, I think we've talked about this before, but it's important to note that upper cervical instability can impact the jaw. And it can impact the jaw because basically when the upper cervical stabilizers go offline, the front muscles, sternocleidomastoid, the scalenes, the strap muscles that link into the jaw go into overdrive to try to stabilize the head on the neck. And when they do that, they put more pressure on the jaw. So if your jaw got severe enough, it could certainly be difficult to talk or be difficult to chew, etc. So we've seen a number of CCI patients with pretty severe jaw issues, and generally what that means to us is in some of those people, we need to treat the jaw and the neck at the same time.
Excellent. Thank you for your question, Lindsay. We have Roger Chin following up. Despite being able to work on my boat this summer after PICL number 2, my symptoms returned in the last month or 2. Same with PICL number 1, where I seem to regress in months 5 and 6. What would cause things to regress? Disorganized collagen that never got fully integrated, got reabsorbed? I get PICL number 3 next week.
Yeah, I think the big question would be how much regression is happening. So, it's really one of those things where all ligament type treatments, what we generally see in most patients, not all, is the patient will get better and then regress a little bit, get better and regress a little bit, get better and regress a little bit. And it kind of goes on like that. So as long as you're holding on to some gains from each procedure, I wouldn't be too concerned about that. But what I would say is that the muscle strength, as we've talked about here many times, is a critical component, right? You've got half of stability that's ligament related, half of stability that's muscle related. So if you're feeling good during those times, you're going to want to strengthen those muscles because that's what's going to really, really allow you to supercharge that result. So number one, first question would be, are you kind of seeing this kind of thing, but in general, doing better and holding on to some gains with each procedure? And then if or if not, you've got to definitely add in the muscle component. And then it's certainly possible that we may need to inject other structures that have yet to be targeted.
Nature is rarely that linear, so it's always a progression of sorts. Megan May, hello Megan. She says, asks, how does PRP/stem proliferate?
So I think the question would be, how does it help with healing, or how does it help with ligament strength? And if you look at PRP, the best way to describe the effects of PRP would be, let's say we had a construction site and we had a whole bunch of construction workers there, and we wanted them to work a lot harder. We could certainly go to Starbucks, buy everyone quadruple lattes or espresso shots, hand out the espresso shots, and they're going to, for 4 hours or so, they're going to work a lot harder. Now that's how PRP works. PRP is like an espresso shot for the local cells that are involved in the repair response. And then you've got a stem cell type treatment, and it has that effect, but it also has the effect of delivering a general contractor to the construction site who can help organize what all these workers are doing. And in a weird way, for autologous treatments, that general contractor, once he's done, can also turn into added bricks and mortar, added drywall, added 2x4 studs, etc. So that's the difference between those two. One is kind of a stimulant, the other one is like a general contractor.
All right. She goes on to say, there are lymph channels in the neck, upper cervical area. Mine, as in hers, were affected by traction injury and caused liquid sensations when turning head. Can strengthening help?
That one's a little too specific. I'd need to do an exam and know a little bit more about that one to answer intelligently.
All righty. Thank you for the question, Megan. And again, if you'd like to ask Dr. Centeno about your specific case, just like that, you want to reach out to the Centeno-Schultz Clinic and schedule an appointment either via telehealth or in the office. But thank you for your question, Megan. Stacy, once again, when intermittent fasting, how long and how many hours do you fast for?
Yeah, there's lots and lots of different types of fasting here. I would recommend, just based on personal experience, fasting mimicking diet. If you want something that's kind of off the shelf, there's a company called Prolon, Prolon. I don't have any relationship with them, but they make a very nice kit where you can do a 5-day fasting mimicking diet where it just takes your calories down. And it makes it very, very easy. You just eat what's in the little box. That's what you get to eat during the day. So it also helps to get your head around what's happening. And then you've got intermittent fasting, where there are effects in kind of the 8 to 12 hour zone. So that means, let's say if you were eat an early dinner at 5 p.m. and that's what you're going to eat, and you wouldn't eat anything until 5 a.m. the next day, that's that 12 hours that they usually look for in intermittent fasting. That's an easy way to do it because you've just got the evening and then you're sleeping. Another way to do that would, obviously, you could also mix it up. You could, for instance, one of the guys in my office has been doing this for a while, and he doesn't eat anything but at dinner. So he'll have a really big meal at dinner, and then he doesn't eat anything in the morning or anything for lunch. Now that would be a hard one for me to pull off, working and having to think a lot all day. I don't think I'd do too well on that. So for me, I'd rather the other way of doing it.
Right on, Stacy. Thank you very much for asking. Let's move to Andrew Ryan. When receiving PICL plus cervical posterior injections, do you try to maximize the blood draw so you can inject, strengthen additional nearby aspects in the chain, upper thoracics, traps, shoulders, etc.?
Yeah, that depends heavily on the patient, what else gets injected. But realize that it's pretty standard in all PICLs to inject the C0 through C7 supraspinous, interspinous ligaments. And yes, we can inject lots of other areas, but again, that depends on the patient. So for me, I'm going to put someone into one of three categories. The one category is going to be, I can inject anything in this guy and he's just going to shrug it off. Another category on the other end would be, I have to be very careful to inject as little as possible because less is more. Because if I inject too much in this person, they're gonna go thermonuclear on me. And then there's the in-between patient where you kind of got to respect it, but you can get away with a little bit more. So that's the first component. Then the second component would be, what specifically do you need injected? And yes, it would be common that we inject upper traps, obviously common that we inject all the posterior ligaments, common that we deal with thoracic issues if they're there, shoulder issues if they're there, et cetera, et cetera. That usually comes, that can come from PRP, and the PRP now generally comes from the bone marrow aspirate. We do that for two reasons. Number one, because we can, meaning we're the only people that can do that, meaning you can't just put bone marrow concentrate into a machine and have it produce PRP. The second reason we do it is because it's more sterile. It also reduces stops for a patient within the office. So they just go get their bone marrow aspirate. Everything is taken from the bone marrow aspirate, PRP, bone marrow concentrate, et cetera. And they don't need to go and get a separate blood draw, which saves a little bit of hassle for the patient. It's also done, the draw is done under an extremely sterile environment, simply because we've got a full surgical prep, very different than a blood draw, where obviously everyone keeps it as sterile as they possibly can, but it's never going to be anything like a full surgical prep like we would use in a bone marrow aspiration, where the doc's got full sterile stuff on, the sterile field is the whole patient, there's a sterile tray set up, et cetera, et cetera.
Just want to check in on your time. We got a lot of people still watching and a lot of questions still here. We're at the top of the hour. You're okay?
Yeah, I think I get another 15 minutes. I'm good.
Sounds great. We'll keep it rocking. Adrian follows up with, neutral rotations of a vertebra, C2 specifically, seem to be a problem that resists treatment. Is that consistent with what you see? Does the constant stretch on the alar ligament reduce the tightening impact of the PICL? What can be done?
Again, I think we've talked about this, and that is that you have C1, C2 that are convex on convex. And so if you get any type of ligament laxity, it has to rotate. There's nothing else it can do but to rotate. And so what I mean by that is that rotation is not the exception, it's the rule. In any patient who has any type of alar or accessory ligament laxity. So just realize that that rotation is just par for the course. And it's not an unusual thing or an unusual problem to see. Now, if we think it's a big issue that isn't getting better, which is tightening down the alar ligaments, we can try to preferentially tighten certain tendons, but in my experience, that generally doesn't work, and we're headed towards a PICL failure in that patient. So just realize that rotation is not some unusual thing. It's in pretty much every single person that has any kind of upper cervical instability.
It's kind of a natural physics kind of thing. Here we go. Stacy Kaufman once again. Each of my 3 PICL recovery times was different. And for me, more injections meant longer recovery time, but better healing of the injuries. Excited for Dr. C to inject the heck out of me for PICL number 4.
Yeah, happy to do that. But again, as I think I've talked to Stacy about, and I know, we've talked about here today, just realized that it's always a little harder there because, again, we're trying to walk that line, and we just don't want to push people over the edge. What I mean by pushing people over the edge is that in patients that are centrally sensitized, and centrally sensitized means that they'll have big flare-ups from procedures, we have to be careful, meaning that, I go in and I get injected. I don't care how many areas they inject, meaning they can inject my neck, my back, my elbow, my ankle, my knee, and 5 other things. And I will be sore, but nothing that a week couldn't handle, or even a day or two, meaning my average turnaround time from injecting all those different areas or having someone inject all those different areas in me is 1 to 2 days. Meaning if I'm not working out by the 2nd or 3rd day, then there's some sort of issue or problem. Now that's the typical response to orthobiologic injections, unless you've got something specific like a knee that'll blow up after bone marrow concentrate and you got to give it 3 to 7 days. But if it's taking longer than that to recover, there are other things going on. And one of those, it could be central sensitization, meaning the nerves are too efficient at carrying pain signals. Another one of those could be just systemic inflammation in that patient, meaning where it's too high. So just realize that we always have to be careful because we can push people over the edge. I've seen centrally sensitized patients where if they get a procedure done, it'll take them a year to recover. Now that is totally abnormal. There's nothing even close to normal about that. But it happens. So we have to be careful there. And so when I've got centrally sensitized patients that aren't CCI, because this exists, the Venn diagram of central sensitization is this big and the one that overlaps with CCI is that big. It's like a dance partner. You can't step on their toes. If you do, the patient's going to pay for it. So again, in those patients, less is more. On Stacy, we will try that, but realize that you got warned that less is more.
There we go. Right on. We've got, I believe, a new viewer here. Elvis Berger. He says, hi, follow from what I believe is Sweden, a country without PRP or other help with AAI-CCI. How long time take one PICL treatment from head to C3? It is very painful under and after treatment, writing with Kelly at the same time.
I'm not 100% sure what the question is there. Are we asking about how long the procedure takes or how long the recovery takes?
I think it looks like how long does it take from head to C3? Is it very painful under and after treatment? So I think it seems to me like it's asking how long does the procedure take, I believe. And is it painful during and after?
Yeah, so during you're going to be asleep. And well, you may have intermittent memories here and there of what happened. You're not going to have a lot of memory of what happened. When it comes to after, that's kind of what we were discussing before, and that there's sort of 3 different patient types. One patient type where there's going to be no real issues with recovery. The recovery will be short and quick. On the other end of that, the recovery is going to be long, and then in the middle. So I'd have to know which of those 3 categories you're probably in. If you're in the longest category, then recovery can take anywhere from several weeks to several months. If you're in the shortest category, recovery is going to be at most several days. So just realize that that's pretty different. Now, the funny thing is, and this is just a complete aside, we've got lots of people in America that want to go to a Swedish type healthcare system. And, there are certain advantages and disadvantages, but, it's good to hear, because I've seen this my whole career. I've treated patients from Canada, I've treated patients from all over Europe. And, those health systems are great in that they can deal with common things pretty efficiently. But if you have an uncommon thing like CCI, very, very hard to get any healthcare that will help in that system, and no one's incented to help you. So I feel for you being in the Swedish system, because I've heard this my whole career, whether it's Sweden or whether it's Canada or elsewhere. It's very, very hard to find people who will dig in to a complex problem like this, because there's just no incentive for anyone to really want to do it.
The system's complex, both in America and internationally, for a lot of those reasons. If you'd like more information about it, you should maybe set up a consult again with Dr. Centeno virtually to learn more about your specific condition. Let's go. We got a few more left. We've got Shanze once again. Follow up on Adrian's question regarding persistent C2 rotation in neutral even after regenerative treatment. Could that be indicative of an issue with suboccipital muscles, which can be helped with PRP and the muscles and strengthening exercises? Thank you for all your answers.
Yeah, I think that what we're dealing with there is probably one of two issues. The first issue would be that the damage is such that we can't heal it, in which case you're going to see a persistent rotation. The second issue would be that there's something else leading to the rotation. And oftentimes that something else could be, for instance, scoliosis in the cervical, thoracic, and lumbar spine, which is putting a rotational momentum up there. You could also see that we had one patient who had a disc replacement lower down that was off center, and it was causing a rotational moment up top. So those are the two major issues there. And then a third, as you brought up, would be the need to strengthen, because again, half of this equation is ligaments and half of this equation is muscles. So we have to get those muscles, suboccipital muscles, that would be correct here, strong enough where they can also fight that rotation. So either the injury is too big, there's a rotational moment coming from someplace else, or the muscles are just too weak and the ligaments can't do it all by themselves.
There we go. And that's why it's always a Sherlock Holmes mystery to sort of figure out these things. These are the processes to learn. And that's why you need a great doctor who's willing to put in the time to investigate these things, as opposed to do what you think you want, which is, here's the drug, it's covered by your insurance, good luck to you, see you when it hurts again, which is unfortunately the common standard of care. Doug Smith says, thanks, I understand now, appreciate the explanation. Doug, thanks for watching, and glad it was helpful. Stacy follows up, she says, this cell count stuff is very confusing. I guess that's why you have the title of doctor and we don't. We'll wrap that up in just a few moments, Stacy, but it is confusing. But that's why we're here, is to hopefully try to clear some of that up as we go on. Livia Benko, also a regular viewer. Hi, Livia. She says, how strong is the newly formed ligament tissue from the stem cells in comparison to the natural ligament tissue? How do the stem cells impact the healthy, uninjured parts of the ligaments when injected?
Yeah, so I can only tell you this from studies that we've done in much larger ligaments that are much easier to image, and those are ACL ligaments in the knee. Meaning that not only is the ACL much larger than the little ligaments we're talking about, but imaging it is much easier, and obviously it's done all day, every day. So we've got, knee coils that are designed for that. We've got knee image sequences that are specifically to image ACL. And so when we treat ACL injuries with bone marrow concentrate injection, and see differences on MRI in a high percentage of those people, meaning those ligaments go back to very close to a normal appearance on MRI. So an abnormal appearance is big and blown out. A normal appearance is tight and strong or darker on the image. Now, there are parts of those ligaments in many of those patients that aren't damaged at all. And we've never seen an issue or a problem with those parts of the ligament that also get injected. So I'm not sure if that answers your question in its entirety, but in ligaments that we treat and that we can follow like that and easily see on MRI, they tend towards getting better without any issues. from the normal parts of the ligament, if there are normal parts of the ligament. Some of those don't have any normal parts, and about half of them we treat do have normal parts.
Excellent. Ilmas Ashraf says, hello, Doc. Ilmas, thanks for watching. Glad you're here. Daniel Semrad joined us and went ahead and re-answered all of his questions, Daniel. Please, we did ask them in the beginning. We're glad you joined us. You can watch the replay, and hopefully Dr. Centeno got to all of them. If not, you know where we'll be Friday and next week as well. Let's keep the conversation going. Thank you for asking. Shanze follows up, if I may squeeze in one more. Yes, you may. How is radiculopathy treated with regenerative injections? What would that include, including PRPing the disc or ligaments and take pressure off the nerve? Thank you so much.
Yeah, the most common way we treat radiculopathy, and just to define that for everyone, radiculopathy means that a spinal nerve is really irritated, is through the injection of platelet lysate, so the growth factors taken from PRP, and then that's around the nerve, or called epidural, and that's pretty darn effective. I'd say about 80% effective. Every once in a while, we'll have to treat the disc, so that's possible, but usually not common. And if it's radiculopathy plus degenerative disease, then we will treat generally the ligaments as well.
All right, we have our last two questions coming up. This one from Kara Vogel. Kara says, I was treated at your clinic for 2 disc tears in lumbar spine 16 weeks ago. I feel great now, basically 100%, and I'm back to most of the activities I was doing before. I've had a few very minor incidents where my SIJ would flare up for a few days, but it goes away. My PT confirmed it is the SIJ and not a disc. I've never had SIJ issues before. I wonder if this could be just part of the healing process and tissue remodeling from the PRP.
Could be. Certainly if you had healing of the disc tear, then the rotation that happens in the lumbar spine as you walk would also be accompanied by that rotation in the SI joints. So the SI joints would rotate. That then rotates the spine this way, which then torques those discs. So it's certainly possible, if it's L5S1, that there's some additional rotational momentum going to the SI joints, and perhaps the original injury had some effect there, and now you're beginning to see it. So it could be a kinetic chain issue. It's certainly possible that some SI joint treatment might be needed to round that out, or it's also possible to just kind of go away by its own. So I think give it another month or two, have your physical therapist treat it and see if it goes away. And then if not, we'd be happy to get involved to see what's happening.
There we go. Glad you're feeling better overall. That's fantastic. We've got Arpita, last question for today. How soon is too soon in between prolotherapy treatments?
We generally don't sequence prolotherapy treatments any sooner than 1 to 2 months apart. So the soonest we would look at is doing it about a month apart. Now, I know there are providers out there that'll do these in rapid succession almost every week. Not a big believer that that kind of thing is needed. Not a big believer that that kind of thing produces any better results. So for instance, in a 3-month period, the most we would do is 3, but there are certain providers out there that'll do 9 or 10. I don't think 9 or 10 is going to get you any further down the road in a 3-month period than 3. So consequently, we don't do that. The other problem there is obviously the more procedures you perform, each one has a certain risk for infection. So if you expose someone to 9 or 10 of them, then the aggregate risk is more than if you expose them to 1. So our goal is to expose you to the smallest number of procedures possible that'll get the job done.
All righty. I'll just give Elvis his last comment and we'll wrap up for today. Elvis says, thanks for the answer. It's correct. I have not found anyone in Sweden with instability that Swedish healthcare systems have helped. Only few people with the same diagnosis, AAI-CCI, they have to pay for surgery in the US and Spain, but I get rejected directly. Can't reach out in the newspaper with my story like they don't have help, I believe it says. He says, thanks for the answers and have a great day. So Elvis, you are welcome. Hopefully that was helpful. That is our very long show for today. Stacy also says thank you. We say thank you as well. Doc, today's episode was about what does the TNCC, stem cell count, mean with regard to the PICL procedure. Why don't we wrap up today's show? Please give us a brief explanation for those that came late.
Yeah, I was trying to think of a good way to explain a threshold problem, and maybe a good way to explain it is in terms of gas, right? You go to the gas pump and you see those numbers, 85, 87, 91. Those are octane levels, and we have some idea that that has to do with the potency of the gas. Now, what would happen if those octane levels were 25? My guess is you'd put it in your car and your car wouldn't start, right? There's a certain amount of octane that needs to be in that gasoline that allows your car to start. And so we're really talking about the same thing here when it comes to any kind of cell-based procedure. There's a threshold, and you've got to get past that threshold in order for the procedure to work. So your goal is to concentrate that sample enough where you're generally high above that threshold. So if there's some variation from person to person, you're still well above that threshold. Now, if you don't concentrate it enough and you're way down here, then some of these people are not going to get an effect because you're below the threshold, and some of those people will get an effect because you're above that threshold. So just rest assured that when we do a procedure at Regenexx, we're concentrating this enough where we don't believe there's any type of minimum dose required in general for the PICL to be effective. Now, that doesn't mean we might not have 5% of our patients that are just too sick or too ill or have other problems where they're going to have issues with healing and ligament problems in general, or their stem cells are not real good because of all the other medical problems that they happen to have. But in general, there really isn't a reason to focus so much on this TNCC number for a Regenexx procedure in your PICL or in those ligaments through a PICL. So again, just think of octane in your car. Should be, 85 is what it says on the pump, or 87. If I reduce that to 25, your car is not going to start. It's below the threshold. But we all know that there's regular gas, there's unleaded, and then there's the premium. And our car is going to work with all three of those. We're not going to have any problem getting from point A to point B. Maybe we'll notice a little difference, but the difference isn't enough where we're going to really notice it a lot. But if that number was 25, that'd be a big problem.
Sounds like if there's enough, it's enough.
There you go. That's it. There you go. That's another way to put it in a couple words instead of 35 sentences.
Anyway, thank you all for watching. We really appreciate it. We love your questions. We love you leaning in and thinking through these different processes. It's fantastic. It's why we do what we do, and it's very rewarding to see all of you learning and growing. If you want to do that each and every day, make sure you're signed up for the Regenexx blog. That's Dr. Centeno's daily blog. We're on 3,000 and some odd days in a row. If it is hard enough to stay up reading them, let alone writing them, kudos to you. But if you want to stay smart, you want to stay on the cutting edge, make sure you are subscribed to that. We thank you for watching. We thank you for sharing this program with others. We know you're not the only people that want to get smart and learn about these things. So if everybody just reaches out to a friend, a family member, coworker, somebody that you know, and say, hey, you want to learn more about your body? You want to learn more about how you can take back your power as it relates to reducing your pain, staying healthy, and navigating this insane healthcare system that we're in, then please invite them to tune in with us each week. Stacy says thank you. Roger says thank you. Arpita says thank you. We say thank you. Until next time, I'm Dr. Jason Deitch on behalf of Chris Centeno. Have a great week, everyone. Stay well and be kind. Thank you for watching.